something that has changed over the last 4 months is the COVID experience and dealing with COVID in our medical centers and our institutions and in our patient population. So I think Dr. Shadman and Dr. Allen probably have more experience than Dr. Burke and myself in terms of dealing with COVID positive patients, being in Seattle and in New York City, respectively. So we'd like to, I think, hear a little bit from each of you in terms of how you're managing patients in the watch and wait, particularly thinking about COVID. Do you do different things for patients with CLL in the COVID era that you didn't do previously? And what has been your experience with COVID in the last several months?
Yeah, sure. This is a very dynamic situation. The prevalence of COVID-19 is changing. When we were at the peak of the pandemic, we made decisions consistent with what has been published by different expert groups. In general, for patients who are in the watch and wait basically period, most of the time conversations about starting treatment are not basically overnight conversations. We usually have weeks or months before we know that or before we start a patient on treatment. So with that, a lot of patients who are in need of treatment can wait, and the treatment could be delayed for weeks or months. And for example, if somebody who has in a patient who has a low blood count, for example, thrombocytopenia, but not at a high risk level, we would be able to monitor that patient closely. We utilize local labs for these patients, for patients who come from areas that are not very close to our center, and we use telehealth platforms and telemedicine to talk to them and review their lab results. So this has been our practice in the past few months. As things are changing and as we've passed the peak, we are starting to kind of slowly go back to our normal practice. There are patients who are in need of treatment, and I think it's very important to emphasize on the fact that it's always important to make sure that patients who need treatment, we are able to offer that treatment. Unfortunately, we have had a few patients who were not referred timely or decided to wait until the pandemic is over, and we had a more complicated situation in terms of starting them on treatment. In patients who are on treatment, and especially those are on novel agents, if they have a stable disease and if there are no side effects, we try to minimize their visits. And again, we utilize telemedicine and using local labs when possible. Most of the time, if they receive intravenous therapy, for example, using monoclonal antibodies in combination with some of the novel agents, those treatments most of the time can be skipped or delayed, and we have been doing that. Really, the strategy is to minimize patients' exposure to the health facilities and try to really helping them practice the physical distancing that we are advising them to do.